Once again, good afternoon. My name is Lee Jones, and I'm the CEO of GSI Health, and I want to welcome you to our webinar on Beyond the EHR, an Integrated Population Health Management Strategy. And I want to start by going through a few housekeeping items, and then we'll jump right into the topic at hand. There is in your webinar panel a section for questions, and so if during the discussion you have any questions, please feel free to type them into that section, and after the presentation I will go through and address all those that are there. All of the lines are muted, so you aren't able to orally ask your question, so we ask that you would do it this way. Many of you have been invited to the webinar by various people at GSI Health, or you may have found it on your own. We do have an attendance of all those who have registered and who've actually logged in to be with us today. And so we will send you a link to the recorded webinar and the materials that are used here in the coming days. It likely will be across the next couple of weeks, but given the holiday and a desire for it not to get lost in your email as you may be going on vacation, it may happen in early January. And so, as I mentioned, my name is Lee Jones, and I'm the CEO of GSI Health, and you can read more about me and my background on our website, gsihealth.com. It's also here, but I think that I'll leave that as more of an academic exercise for you, but I will spend a little bit of time telling you what GSI Health does, just so you understand our perspective and what shapes the views that I'm going to be espousing today. So I'm going to talk about population health management broadly, so we're on the same page about what we mean, and you understand what I'm saying as I'm presenting the material. And then in the midst of that definition, I'm going to pull together some discussion points about the electronic health record as a population health management tool unto itself versus an electronic health record that's coupled with a dedicated population health management tool. And I'll tell in a moment, I'll talk about exactly what I mean by each of those terms, electronic health record and population health management tool. Then I just have a very brief illustration to try to drive home some of the points on why this makes a difference. And it's contrived, but I think that you'll understand the point of it, even though it's a fictitious example and the numbers that are used are made up. So GSI Health is a population health management solution provider, and we sell a tool called GSI Health Coordinator, and we define population health management as the combination of care coordination and analytics in order to manage complex populations, and primarily has been applied in the area of value-based care. So we have a very strong presence with Medicaid populations, but the tool is not limited to Medicaid populations, and typically our customers are trying to, they are generally pre-risk, but moving on a path toward being able to assume risk for these populations, and that means that they need to be able to actively manage them, hence care coordination, and also gain insights about the job that they're doing so that they can get better and stronger at that management. And that combination of analytics and care coordination is fundamental to our view on what a population health management tool is. And so when I use the term population health management tool or platform in the course of this discussion, I do not mean population health management as just a set of analytic functions to get insight, nor do I just mean care coordination activities that go into the community. I really mean both of those things to tie together and in a mutually reinforcing way. Similarly, at this juncture, I'll just say that the star of the discussion here is really the electronic health record. And so when I say electronic health record in this context, I'm talking about a software platform that is primarily geared toward the ability to manage populations and to document the treatment of those populations for a given enterprise or care provider. And so the general purpose is to provide a number of different functionalities such as charting and practice management, potentially, and the hospital information system functionality, ordering, decision support, et cetera, but really tied toward the delivery of medical care as a primary focus. I say that because obviously the vendors for electronic health records have many, many modules and add-ons and other things that they sell. And so when I say electronic health record, I'm not really referring to a particular vendor who may in fact have population health management offerings. I'm really narrowly talking about the electronic health record, which generally is used to do documentation and management of the patients who come to a particular site of care or enterprise of care for a provider. And that means that the patients that are a part of the electronic health records domain typically are the ones that have been seen or are being seen by that provider. And so once again, this is not to say that electronic health record vendors don't have other tools that they sell, but when I say electronic health record in this context, that's what I mean. All right, so with that introduction, I want to just talk a little bit about population health management and our view on what it's comprised of. So when we talk about managing populations, there are different levels and breadths of scope that one can refer to. So a common case is the case management scenario where there may be an acute care facility that has a population of patients census that comes through that facility, and the extent to which care is delivered within the facility and potentially outside of the facility may be managed by someone who's assigned to a patient's case. And that case management professional may do a number of different things that are analogous to what we see in population health management in terms of being an advocate for a patient, trying to make sure that the course of care goes smoothly, removing obstacles, but they also often have a role of optimization for different activities for the provider itself. So making sure that eligibility and billing are aligned correctly, and other functions like that. That's sort of a long-standing set of functions that providers have. And as you start to see systems get bigger and integrate a number of different providers beyond the walls of a hospital, then we start to get into this idea of care management, where there are partners who are also integrated into the care, and those partners may or may not be affiliated under the same banner or organizational lead as the anchor tenant of the network. And so in this diagram's case, there may be a hospital system that has some employed physicians who have practices in the community, but also there may be some who are not employed, but they're still considered part of the network, whether it's a referral network or others, because they provide services to the same population. So we call that care management, because by and large, the anchor tenant of this network still controls the participants and has some authority to impose the rules and workflow that they operate under. But then when we start to move from case management to care management, there is a transition into accountability being extended to a team beyond just one organization. There are likely some shared systems, probably an electronic health record system, when most of the participants are under the same banner. And the ability to have change management is enhanced because the anchor tenant has so much positional power. We also can start to take into account other dimensions of a patient's need, whether they're social work or other things. But systems can start to move into this new level of care management. But then to get to population health management, we really are talking about bringing the broader community into the fold. And when we bring that broader community into the fold, there are a number of different partners that may be unaffiliated. There may be out-of-network providers who provide services to the population but don't have any kind of relationship to the network and the network's goals. So as we move from care management into population health, we see that there's some shared control of the network in terms of formal financial relationships that each partner is responsible for and has access to and gives them a seat at the table. There's often a number of different technologies present, and so there's not necessarily just one electronic health record that can be proliferated everywhere, but there may be multiples and a resistance to supplant the existing electronic health records in any organization by someone else's. And then the workflows that have to meld together across those different organizations might be more challenging. So this broader community-based care paradigm is really where a lot of the population health management activities are taking place, particularly as they support value-based care, and a number of the tools in the marketplace are addressing this kind of network. It recognizes as well that even when there is a network that is established for population health management, the out-of-network providers still play a role, and there are other considerations that come into play. So when we talk about population health management at this community level involving all these different kinds of partners, it has implications on what we're talking about when we say a population. So the anchor tenants or the systems or the physician groups or whoever the providers are that are organizing a population health movement, they will bring to the table their history of patients, likely captured in their electronic health record. So the enterprise that is the anchor tenant for the population health management activity has a number of patients over time. They may have a number of different sources or relationships with payers to get data, but they have some body of patients. Similarly, the partners who are grafted into the network for the purposes of managing their common patients will have their set of patients that they are bringing to the table. And they may be outside of the electronic health record, may not have been seen by the anchor tenant, may be resident in other kinds of tools that are not electronic health records, but nonetheless represent a segment of the overall population, and they're being brought to the table by partners. And then what's often the case in population health management is there could be some broader definition of the population that the network is responsible for. So it could be that there's an attribution that is given to an organization that has taken on a contract for managing population, and that attribution could be a number of named individuals or a description of a number of characteristics about the population, but it may very well involve patients that have not been seen in the network or do not have data resident in any of the systems in the network. And that patient, those patients who come from out of network, either providers or are simply off the grid, also contribute toward what we define as the population that has to be managed. So all of those different patients sort of come together, and the task is to manage them under a common set of rules and governance so that population health management can go forward. And so there may be some characterization, as I was just stating, of what the population means, and there's a proactive definition and segmentation of that population, and this is something that many people associate with population health management, this idea of gathering a population together, doing some predictive analytics to understand how they're segmented and where you should spend your time. This is often taken as sort of a fundamental tenet of this idea. But once there's a characterization of entire population, there have to be specific patients that are associated with those segments. It's not enough to just describe generically what a patient group might be, but for population health management to go forward, you have to understand specifically who those patients are. And then you can decide after this, which segments are important for you to do any kind of preemptive intervention in order to move them out of the risk areas that you're concerned about. So there's a proactive choice of what the plans are for the patients that you discover that you're able to make an impact on. After you identify who those patients are and decide how you want to handle them, then there's often an outreach period to try to make contact with those patients, to locate them, to organize them, to get them on board, and then some level of engagement to proactively establish some logistical and administrative patient links. How is it that we're going to have contact with this patient? Are they enrolled in particular programs? How is it that I think about them? All of these activities can happen in a proactive stance when you take into account the entire population and do that work. Then, if there are specific interventions that could be had prior to an episode that you may be trying to optimize, then those interventions can be had, and the proactive nature of population health management is sort of displayed through this chain of events. But then there is management of the patient population as they come across the threshold of any provider. So rather than going out and finding patients and engaging them in the way I was just describing, often what is done is the organizations will wait until patients present themselves at one of the partner organizations, and then the population health management activities will begin. And I think that this is done because of some of the premature state of predictive analytics and the lack of resources to do a lot of these proactive steps by a number of programs and organizations. And so there's often a big effort to try to catch patients as soon as they cross the threshold and then do a number of different things with them. First thing maybe is diverting them to the appropriate care level, trying to reduce ED utilization by catching patients as they come to the ED and directing them to other facilities or sites of care that might be more appropriate. So for many, this stage is really the beginning of population health management rather than all of these other proactive pre-episode activities where you're going out and you're trying to find and corral and intervene in a population's health rather than waiting for the population to come and have an encounter with the healthcare system. Once a patient presents, then the encounter that starts the episode of care for that patient is had, and that initial service is provided. And once the service is provided, you can do the similar steps that you would have done in a preemptive stage, identify where this patient falls inside of your population health management set of definitions and cohorts that you're concerned about, deciding what you're going to do now that you understand how the patient presented and what their issues are. You can make a plan for their future activities. And so there's still the idea of looking forward as opposed to just documenting and treating what's in front of me is still here. And so this is a part of the population health management care cycle. engaging with those patients, doing any kind of logistics or administrative activities required to make sure that they stay on the radar in your population health management program, and then all of the subsequent interventions after the initial encounter that are needed. And that orchestration would happen across that entire community as necessary and called for by the case of the patient. And if all of that is done well, then the patient gets better, does not need, hopefully, this level of increased intervention, and is able to exit active care management. And the episode concludes, and the patient is now also available, because they've been seen and documented, available for some of these kinds of proactive steps on a go-forward basis, depending upon how they're tracking. So when we're talking about population health management, and this is really where it becomes important to think about what the EHR is doing in this realm, the entire population that we ultimately care about are the ones who are going to present themselves for these episodes that need to be treated. And often the task of population health management is to optimize or achieve certain metrics around these episodes, and so that they either decrease cost or they increase quality, or both, or other kinds of outcomes of interest. But the population that comes across and experiences these episodes comes from multiple places, as we talked about on a previous slide. They could come from out of network, and the general attribution that is part of the definition of the population. They can come from partners who are not sharing the same technology or data with the anchor tenant. And they certainly can come from the anchor tenant in their electronic health record. If the anchor tenant decides that its definition of population health management really starts when the patient presents, managing them through these episodes and waiting for them to present again, they're sort of cutting off the ability, or the opportunity, I should say, to treat these other segments of the population in a similar fashion. And so it becomes important that if the electronic health record is going to be the population health management tool, it needs to have accommodations as a part of its capabilities that will enable the set of partners who are also on this journey with you, as well as taking into account the breadth of the population definition that goes beyond who is being seen. Now, historically, this has been a little bit of a challenge when we talk about electronic health records, because electronic health records for a long time were thought to be, not thought to be, sorry, still are, but they were discussed in terms of being the legal record, a replication of the documents that we for so long had held in paper. And this idea of the sanctity of the electronic health record system not being polluted with lots of patients who have not crossed the threshold, who have not received treatment, who have information coming from sources that may not be validated, that sanctity was often protected. And it meant that looking at a population as a whole, when it involves patients that have not already been seen by the organization that has the EHR, limited the EHR's ability to do a population health management effectively. And so something else needed to be brought into play in order to do those other kinds of population health management functions, whether it's a data warehouse and a set of analytics, or care management tools or care coordination tools, or combination thereof. But something beyond just the electronic health record itself was thought to be needed in order to do this broader scope of functionality. And so that is essentially the crux of what we want to look at here. How is it that if that's the case, and we understand that ultimately with population health management, we need to take into account the entire population, how is it the case that many organizations lean on their electronic health record and try to do this bigger function alone? So I think that the reason that that happens is because population health management and ultimately what it can gain or how it works is murky, because it's defined often by some of the programs that are offered by various payers. There may be multiple of these programs that are working at cross purposes. There are different things that vendors are saying about what it means and what one should be doing. There's immature literature to define how the population health, the pot of gold at the end of the population health management is actually achieved. All of these factors, I think, just lead people to try to use what they have, and what they have is often an electronic health record. So I want to just, in the next series of slides, talk about some of the principles that underlie population health management, and then talk about how the electronic health record as a solo tool would stack up against fulfilling those principles of good PHM. So the first principle I would put forward is that in this community-based care model, team members should share common tools. The whole idea of moving into a community-based model is to try to form these cross-discipline, cross-organizational teams and have them actually function as if they were one organization, one entity together. And the more similarities that that team has in terms of the tools available to it, the workflows that they subscribe to, the authority and governance that they submit to, the more effective the team is going to be. If everyone on the team is really an independent agent and is just behaving as they will without regard to the rest of the team, is bringing and using the technologies that don't have any synergies with what the other team members are using, then there are problems. So one principle that really supports an effective workflow is that the team members should share common tools. So if the electronic health record by itself is going to be a population health management tool, then it needs to be ubiquitous. And there are some places where there is ubiquity in a geography of a single electronic health record technology. So Epic comes to mind in its idea of Epic Everywhere, where they do have geographies where they are the dominant player, and literally every provider, at least medical provider in the geography, is using the same tool or some tool suite. If that's not able to be done because there are multiple electronic health record systems in the mix, or if there are other kinds of care providers that do things like human services and social services or behavioral health or ancillary services or long-term care, etc., and those are all a part of the same network, then it's very difficult to proliferate one electronic health record above all others. And often what is done, because population health management is an activity unto itself, is there's a consensus to get a population health management tool which will be common to everyone for this purpose. It's not meant to supplant or replace the electronic health record and what it does for every organization. It's meant to address a new need for population health management and to co-opt all of those different tools in the ecosystem and bring them to bear for this purpose. So an electronic health record solo likely would violate this principle unless they have such a strong ubiquity in the geography that it was easy to get everyone to do the same thing. A population health management tool or platform is sort of a shared tool for this purpose by definition. And so unless the governance of the network allows people to, as I say, BYOT, bring your own technology, then the purpose of having that tool is that ubiquity, and all the team members would have common tools. A second principle that supports workflow is this idea of not having duplicate data entry. And I can say from experience, when we go out and service our customers and bring them live, this is always top of mind as we go through implementation. There are existing systems and everyone is very busy doing their jobs and no one wants to repeat the same information across multiple systems. And so if there's an electronic health record that has a number of things that you have to record notes there or care plans there or whatever it may be, no one wants to do that again in a population health management tool. And so this idea of preventing the duplication of data entry is another principle of doing good population health management. So this is actually difficult just on its face, and no matter if you're using an electronic health record and there are other EHRs in the ecosystem, or you're using a population health management tool and there's heterogeneity, it's likely that there's going to be some level of duplication unless there's a strong commitment to integration and interoperability, or there's a compromise and some systems are designated as the source of truth for particular kinds of information. So I would say that, you know, a population health management tool and an electronic health record trying to serve as that in that capacity are essentially similar on this score. This is just a difficult issue to entirely escape. Another principle that has to do with getting the outcomes that are desired is that the pertinent data for care coordination and population health management needs to reside and be accessible in whatever the shared tool is. And so all of the different sources need to contribute to the body of knowledge and body of information that's used by the care team that's using the population health management tool. And so for similar reasons as was discussed previously, the electronic health record trying to amass all kinds of information from housing organizations and food organizations and other social and human needs organizations to behavioral health to medical issues across different providers and specialists, et cetera, is almost untenable when it's paired with this idea of maintaining the sanctity and utility of the electronic health record for its primary purpose. And so it's not impossible, obviously, but it's in my experience unlikely that all of that data is just going to an electronic health record. Again, with the caveat that I gave earlier about electronic health record vendors have other products that they sell. With population health management, that is really the purpose of that tool. And so even whether it's a data warehouse that is being used for population health management, or it is a population health management platform akin to what I described at the top of the call that has an integrated data warehouse, its purpose is to aggregate that data. And so the population health management platform coupled with the electronic health record can often cover the waterfront. And it can take data from different kinds of sources. So claims data and clinical data and the data that's generated through coordination in terms of care plans and other things can all sort of be co-resident and managed and brought to bear for this specific activity of population health management as opposed to the network of activities that an electronic health record has to contend with. Tools, the next principle that has to do with workflow are tools that are need to be optimized for use across the community. And so one of the concerns with using electronic health record by itself for population health management is that electronic health records frankly do lots of things. And that lots of things have a number of things that are you know, on the fringes and may not be necessary for the care coordination activities or the population health management activities. Care managers don't need to necessarily be involved in all of the things that are optimized by electronic health records for an enterprise. How is it that a practice is managed? What is the revenue cycle management? How are things coded? Eligibility checking, figuring out how I translate what's happening in an operational sense in the community into this medical context in which the electronic health record lives. Clinical decision support that's specific to treatment as opposed to the broader coordination kinds of activities. The EHR has, is a mature product that really is focused on a number of things and have been optimized for those things over time. And so bringing it into this new context for population health management, where many of the concerns are around care transitions and tasking care team members to perform different interventions, having a streamlined view of what care is needed without all the detail of how the treatment is going to happen at any one site, really focusing on the outcomes of those interventions. Eligibility checking in a different sense. Is there applicability to the programs that the population falls under, as opposed to understanding some of the payer-specific concerns that one enterprise might have. Accommodation of psychosocial users and data, and doing analytics to gain insight on that data for the purpose of improving the care coordination activities. So when it comes to being optimized for population health management, there's just a stark reality that the electronic health record is parlaying its presence and footprint into the population health management space, whereas a number of the population health management platforms are really designed for that space explicitly. And so having that optimization for the community is more important than having the optimization that you see for electronic health record. So EHR is trying to be the solo population health management tool. Likely have a hard time overcoming this kind of principle because they're good at lots of things, and unless, again, the vendor is sort of streamlining for this explicit purpose, it's not the ideal. But when you pair that EHR with a population health management tool, then you can almost allow the population health management tool to be the manager of the episodes and allow the electronic health record tools to be the manager of the encounters. And so the encounters are hanging onto the episode and give a longitudinal view of what was done in a detailed way by referencing the detail, the rich data that comes from the electronic health record. And so the coupling of those two are much more powerful than either one of them being alone. Another principle is harmonizing any overlapping features. So there are certainly things that are discussed in the population health management context that electronic health records have an equivalent notion. There are still notes that are done, progress notes and case conference notes, and the concept of a care plan is very big in population health management, and a lot of electronic health records have care plans of different kinds, whether they're patient-facing plans of care that are meant to instruct the patients about how to adhere to their care beyond any one encounter, or they are plans that are provider-facing so that they can understand what's going to happen in the future for a patient, or some combination of both. If you have the heterogeneity of the network and that those electronic health records have overlapping functions with the population health management tool, there needs to be some agreement about how that is reconciled. Otherwise, lots of confusion ensues. People use the same terms even though the way that a care plan might be defined in electronic health record is different than is defined in the population health management tool, and people think that they're communicating and they really are talking past one another. And so, again, unless the EHR is able to just be the single platform of overcoming all of the heterogeneity of the network, it's likely the the same kind of effort that will have to happen even if a population health management tool is present, because there has to be a concession that some functionality may be subordinate to some other analogous functionality in a different system. And that kind of discussion would likely happen in either case, whether you're using an electronic health record solo or population health management tool. The advantage in coupling a population health management tool with the EHR is that there can be some reference and agreement between how this population health management tool treats care plans or notes or whatever it is in relationship to the electronic health record. And so it's not seen as a competitive product as one EHR to another one would be, but it's seen as a complement. And so those kinds of source of truth discussions are going to be present no matter what, but are made a little easier through the population health management tool being present. Another workflow principle that has to be taken into account is that no one ever wants to switch between two systems, especially if that switching is disruptive and not seamless. And so this idea of having to use electronic health record on one hand and use a population health management tool, and the workflow that's required has a swinging back and forth, and in my one job across multiple tools is often viewed as untenable. And so if it's going to be switching, which is almost by definition if there are any multiple systems, then it needs to be seamless. And so the electronic health record, once again, if it's the only game in town, really has an advantage there. However, when there's anything else, whether it's a health information exchange portal or a population health management tool or another EHR, this idea of switching back and forth comes up. And what is typically done is the EHR is king, and people try to force things into the EHR environment because it's the primary tool for the providers themselves. What's happening, though, is in the population health management space, there's a power user in the care manager, care navigator role that's starting to emerge and has different needs than the users of the electronic health records. And so there's a stronger case to do good integrations between these systems and not have this sort of disjoint workflow that has to shuffle between multiple things. Also, we're seeing that the care manager is becoming sort of a broker to bridge the gap when there are users that are only going to use the electronic health record. And so seamless switching is a principle, and it's a problem no matter which combination you use. Another principle that affects the outcomes is using the entire population. And this is actually a big topic, and it isn't often discussed on large stages, but in our experience it's always discussed in every implementation. And that is, where is the population that I'm going to manage going to come from? And that has a whole wealth of issues to tackle. Are we getting information from managed care organizations or payers, claims data? If so, how timely is it? Is it going to be able to impact what I'm doing? It gives me a breadth of information, but maybe I think that there's some clinical detail that the electronic health records need to bring. Oh, and there's an HIE in the community, and that HIE has data not just from my value-based network, but other places. How do we account for those things? All of that stuff sort of comes to the fore, and unfortunately what tends to happen is what I described earlier, which is many organizations default back to, I'm just going to deal with the patients that come across my threshold. And when they come across my threshold, then I will use that to incrementally build up the population. And that sounds rational. However, the strength of population health management is being able to look across all the dimensions of the anticipated patients that you will see, not just the ones you have seen, but the anticipated patients that you will see, and trying to understand what groups or individuals in that population deserve your extra attention. And it just can't be effectively done if you're not considering the entire population. One, because if you do analysis on a subpopulation, the subpopulation's characteristics may not be the same as the larger population. And two, you don't have all of the patients available in order to do those preemptive steps and reach out and do something prior to the episodes happening that bring them across your threshold. The ones that you're trying to reduce often can't be reduced until you're reacting to it. So I'm trying to reduce my ED utilization, but I can't do anything with the patient until they come to the ED. And that is sort of this fundamental contradictory step that that many organizations seem to fall into and not leverage their entire population. And part of it is leveraging the electronic health record and trying to use it as a solo tool often will limit the population to, again, those who have been seen. And that limitation will carry through and sort of decrease the notion of population health management, which has population in its title. Of course, if you have a population health management tool, then in theory, you're poised to account for the entire population, but unfortunately, in reality, what happens is the same questions about where the patient information is going to come from and how it's going to be reconciled and culled out of all its various silos still rears its head, and often even the population health management solution, which is there for that purpose to take into account the whole population, isn't able to get all the information and data aggregated because of those other barriers. And so this supports this general principle of proactive management is employed. And that is, again, another fundamental idea behind population health management, that you're able to actually execute on this, this first set of activities so that you can lessen the impact of this latter set of activities associated with episodes. And so if you're unable to do these activities, a lot of the power of population health management is forfeited. So if an electronic health record system is captive to its population that has been treated and not the broader community's population, either from partners or attributions, et cetera, then it has a hard time to be proactive on the entire population, and also while there's an opportunity to be proactive on the patients that have been seen, often what happens is that's not even done, and the organizations are content to get started by just looking at who crosses the threshold when a patient presents, trying to do some level setting on the appropriateness and level of care, and then start to identify patients who might need future care management in sort of a one-up basis. However, the population health management tools that can be coupled with electronic health record are designed to try to go after those other tenets that I was discussing. And now the principle around federated participation as opposed to proxy. So if you're not able to get your tool into the hands of all of the different users, you can certainly have a command and control kind of structure where maybe a care manager, for example, interacts through various means with the various care providers and is the user of a system for population health, as opposed to all of the different care providers of various stripes are able to have access and contribute into the system independently. And so this is, there's no right or wrong per se, and often there are organizations that have a mix of these paradigms even within the same program or set of programs. But if you're able to have federated participation where all the different providers are coming to the table and actually collaborating instead of having them have a sort of a hub and spoke model where they communicate to one entity but never to one another, limits some of the the efficacy of having a team in the first place. So if you're able to get a federated organization where the care providers actually will use the system for population health management purposes, it's often better. So the same story goes here. The electronic health record, unless it's ubiquitous, will often need someone who knows that system, if it's the primary population health management tool, to be the gatekeeper into it. And that often means setting up a care manager or care management agency who will run interference with all the other providers and record what's necessary. And again, it's not a question of right or wrong, but it is it's this idea of having another intermediary who's interpreting what's happening and bringing that to the team as opposed to getting it directly from the source. The population health management tools tend to be advertised as, hey, everyone can use and should use, but if there's not a strong governance that prevents the bring your own technology mindset, then many of the participating organizations will do that in fact. And then finally, the care teams have to span the different settings and disciplines. And when they span those settings and disciplines, there are a number of different kinds of users that come to the table, whether they're primary care or managed care, social care, physical care, home care, behavioral, ancillary, specialist, acute, etc. All of those different kinds of users come from different contexts, have different sets of expertise and different information that they're interested in using and leveraging for the purposes of participating in this care management activity. That said, the unifying form of communication is quickly coalescing around this idea of a care plan, and a care plan having issues or problems, some goals around those, and a set of interventions or activities that try to address, to meet those goals and address those issues or problems. That idea spans all of these different areas in an abstract way, and they're able to apply it in their specific context and share it in a way that is consumable with each other. So the electronic health record sort of came up in this idea of medical care, and so partners who are not a part of that medical context, or at least not steeped in it in a way to use an electronic health record system, can be challenged in trying to bridge what they do into that paradigm, where the population health management tools, to different degrees and extents, can try to overcome because they're anticipating that diversity in its user base. So I talked about 10 different principles, and in all of these cases, the electronic health record operating as a solo population health management solution has the potential to violate all of them. It doesn't have to, but there are at least 3 or so that almost assuredly would get violated if you had the electronic health record as the only population health management tool. Grafting in a population health management tool to complement the electronic health record has the potential to mitigate all of those different principles, but it still comes down at the end of the day to the choices that are made by the program, and those choices really dictate how well the population health management efforts are going to go. So why is this noteworthy? It's noteworthy because every one of those principles that gets violated has a cost to the program. If you're not able to get all of those workflow issues sorted out, then it not only breeds frustration and confusion among the partners who are supposed to be collaborating with one another, it takes up time and energy to implement workarounds and alternatives to accommodate this variation that is brought about because these different principles aren't adhered to. When you're not able to have common shared tools, when you're not able to get all the data together, when you're not able to look at the entire population and understand how it's constructed, when you're not able to share analytics in a broad way, et cetera, those things have costs. And part of the idea behind this population health management is I'm trying to implement a lean, efficient program that will help me to decrease the cost on something that is much more intense by doing some work that costs less than what I am going to cost less to implement than the amount that I'm going to get back by doing this work in the first place and decreasing the more expensive high utilization scenarios so that I can afford to do it. In other words, if you're trying to reduce ED utilization, and ED utilization costs $10 and you're trying to get it down to $7, if you have to spend $7 to do preemptive stuff and you got the original episodes down to $7, now you're spending $14. And that's really the reason why the construction of the population health management program in a way that tries to adhere to principles that are going to make the team successful and not put roadblocks is so important, because at the end of the day, the only way that these programs are going to succeed is if they're sustainable. And the sustainability question, I think, is looming large now as a number of organizations have run through their ability to subsidize their programs through, pockets of money that they get from places. So the last thing I'm going to do is just talk about a fictitious example in order to try to illustrate the point that I was just saying. And again, it's totally made up, but it is, I think the idea of it is really what's more important than the specifics of it. So I'm just giving everyone a little bit of a nerd alert. I'm going to talk about, dollars and a little bit of math. Nothing hard and difficult, but if you're one who's averse to those kinds of things, I wanted to give you a heads up that that's really coming. So you can start your eye glazing right now and then just listen to what I say at the end. But let's say that there is an attribution of 100,000 patients to a program that is going to manage that population in order to try to achieve some savings. And out of that 100,000 patients, they expect, through some maybe historical analysis, et cetera, that 20,000 of them are going to actually have treatment that's in the category that they're trying to optimize. And of that 20,000, 10,000 are patients that have been seen in the enterprise, i.e. they're in the electronic health record. 6,000 may be coming from partners, but have not been seen by the anchor tenant, may not be in the electronic health record. And then another 4,000 are previously unseen, but we expect that they're going to come in. The cost to treat the 20,000 without any population health management efforts is $1,000 per patient, and again, in this fictitious example, or $20 million that over the period, and maybe that's based on historical trend, and we're trying to reduce that number by 25% and get it down to $15 million over the period. If you're able to do some of the preemptive work through avoidance and decreased acuity, that preemptive work can get you down, all in, accounting for the cost of doing that preemptive work and those interventions, et cetera, a net cost of $600 for every patient, on average across the population of patients, instead of $1,000, and allows, and that's taking into account, again, the cost of those proactive actions. If you're not doing the proactive stuff, just the management of people coming across the threshold according to your population health protocols and your interventions that you'll implement, you can still get that cost down to $800, even if you don't do the preemptive things and you're doing them more reactive. So rather than $1,000, it could be either $600 if you do preemptive, $800 if you don't. But then if you have every principle that we talked about, every one that gets violated by the way that you construct your population health management program is adding $25 to the management of a patient, then how is it that you you start to understand the economics of what you're doing? And again, it's not a complicated example, but you're going to have 10,000 patients that you're going to be able to manage because they're inside of your electronic health record. And if you wanted to do those preemptive steps, then you can do them. And let's say for all 10,000 of those patients, you could get that down to the $600,000. $600. $6 million for the ones that you already understand with the electronic health record as sort of a solo population health management tool. The other 10,000 patients that are not in the electronic health record may come from either out of network or from your partners. You can still manage through your improved processes down to $800, and so you have between them $14 million that you're able to get that cost down to where it was $20 million. So this looks pretty good because, hey, I'm able to do some things for patients that I have easy access to. The ones that I don't, I'm improving my process enough to still save enough money, and my overall costs coming down. Then the question comes in, for all of the patients, though, the efficiency of the process that I put in place for population health management now will determine whether this is my bottom line or whether there's something else that I have to account for. And so in my, again, fictitious example, $25 times however many violations that you had, times those 20,000 patients that you're going to see over the period, can suddenly take away some of those gains. So, for example, this $25, if I had 4 of those different violations of principles, brings us to $100, and then that $100 across all of the different patients, because my same process is being implemented across the entire 20,000. That that $100 adds tax on another $2 million that I could have claimed for the period and every period if I had designed my population health management process in order to account for those things that are going to make it smooth and work well, and not succumb to some of the pressures to do the expedient work of only having an EHR or making some decisions around technology proliferation that don't advantage you. So not a complicated example, but the point is the process matters. And so in summary, allowing your population health management program to be constructed as a patchwork of existing technology undermines your program's efficiency. It's better to think about the population health management activity as a different thing and something unto itself that deserves focused investment and focused design. And allowing the electronic health record to be repurposed to do that work just because you have it is also something that can undermine what you're ultimately trying to do. Again, it's not to say that it can't work, but you should, again, focus on this activity as something unto itself and design what you think is going to be worthwhile, and then decide if the electronic health record that you have can actually do all the things that you need, rather than starting with, we have this, we're going to use this, and then building and accepting the deficiencies just because of that experience. And finally, the heterogeneity in the network should be embraced. The relationships between these different networks is starting to get more and more complicated, overlapping networks, trying to collaborate network to network, bringing not only different technologies, but entirely different workflows and accountabilities and different kinds of relationships and financial incentives. All of that is only going to grow and expand. And so getting used to, we're going to live in a world where there are other things that have to be accounted for is something that will, I believe, play out in the end more prevalently than I can go in and force a single solution on everything, and that's going to survive and take me where I want to go. That means that we have to have a commitment to strong integration and interfaces. Interoperability is still key and still hard, but there are policy and governance issues around how you treat bringing your own technology and having it being a part of the solution instead of part of the problem. And so that concludes the discussion for today. I appreciate everyone's time and attention. And at this point, I will take a moment to look at the question window to see if there are questions that were asked, and I'll respond to them. So if you have questions, you can put them into your question window. I'll give a moment for that to happen. All right, I'm not showing that anyone has any questions about what was presented. So once again, I appreciate everyone's time, and we will make sure that we distribute the link to not only the talk but the materials. And if there are offline questions, oh, I'm sorry, there is a question that has come in here. Do you have any example of population health management tool that's currently being used and a description of how it impacts outcomes versus an EHR? Well, I guess that's a little bit of a a loaded question for me, because our company sells a population health management tool. So so yes, I know of one and several actually, but I know of them and they are being used. And I think that a lot of the perspectives that I expressed are things that we've actually seen in our customer base. And so there's these struggles around how to treat the various electronic health record systems when there's a number of them. Frankly, when there is sort of a dominance of any one electronic health record system, I've seen the tendency to use that as opposed to introduce something else. But even that's changing now. There are a number of Epic implementations, for example. It's just nothing special about Epic, but they tend to have big geographies. A number of Epic implementations that are bringing in tools like this because their care management agencies, et cetera, have are not going to be Epic users, and they really have a different set of things that they're trying to accomplish. As far as any kind of formal comparison that an actual customer has done to say, hey, this is the impact of using electronic health record versus using this other tool. I don't know of anything like that per se, but I think the things that I've described really got at that idea. So there are some more questions that are showing up now. So do you have an example where your clients have used the data captured by your system to improve their interventions and workflow? Yes. So in a number of our implementations, central to our tool is a care planning authoring system, if you will, where they can create care plans, and those created care plans are linked to other things like assessments and alerts and tasks, etc. And so the customers who have been stronger about saying that care plan is the way to document care plan for the program have had much more success in even being able to measure what they're doing. And so, there's one thing to try to improve, but if you can't even measure it because there are different tools that are involved where an electronic health record is doing a care plan here, and another one is doing an assessment there, and there's no standardization, then those customers who take those approaches, we've noticed, have a harder time getting their arms around what their partner is actually doing and how they fit into the picture. And it takes a lot more manual work to reconcile that. So I think that's been our general experience, and certainly we can talk more specifically if you're really curious, and we can talk about specific use cases. Another question: does your tool integrate community level data like food insecurity, homelessness, medical data? Yes, there are different domains that you can assign the problems or the issues to, and those you're able to document extensively either in free-form notes or in some structured paradigm to capture issues and to capture the interventions that are appropriate to whatever domain it is. So yes, we do that. Can you share any outcome to date? I guess I would have to have a more specific discussion about what's meant by an outcome, but I think that there are customers, for example, who have reduced their preventable readmissions by significant amounts, between 20 between 15 and 30%, as one example. Now, can we attribute that to our tool? No, because there's so much that's dependent upon the program itself. So we can say we're correlated with those kinds of results for our successful clients, but ultimately there are so many factors in how one runs the program that it's hard to say that it's because they used our tool as opposed to a bunch of other things that they're doing. Do you provide workflow? I'm sorry, I lost my place. Do you provide workflow design assistance along with your population health management tools as a part of the package solution? So whenever we do an implementation, we do a detailed analysis of the workflow that's envisioned and that exists, and we configure the tool around it, because workflow obviously is very important, as you can see from the principles that I put forward. Has your experience shown that the population health management is more effective among certain illnesses than others? For example, is it more effective for heart failure than diabetes? I don't have any specific data that would suggest something like that. I think we're agnostic to what the actual diseases that are being treated, and In fact, many of the outcomes that customers are concerned with are not necessarily limited to one disease class. They may have multiple programs, and so we don't have any specific data around that. I'm just looking through to see if there are any more. All right, I don't see any more questions being logged. And so with that, then I'll thank everyone for your time and your attention. And I hope that you're able to go off and think more critically about the population health management programs that you're involved in and how they can best be constructed so you can be successful. Thank you very much, and have a very happy holiday season, everyone.